to hit record. If I can find it. Okay, all right. So, virus, variants, vaccines, and volunteers. We are very, very excited today to have Carly Rebelo and Dr. Alon Vaisman, I hope I'm saying that right, join us to answer questions for you guys that you've actually voted on throughout the last 2 weeks. I'm going to do a little bit of an introduction. I stole their pictures from their social media, so I hope that they are okay with that. So Carly is the manager for infection prevention and control here at UHN, and Dr. Vaisman is an infectious disease doctor at UHN as well. So those are our lovely experts. If you guys want to unmute yourselves and say hi, go ahead.
Hi, everybody. I'll go first. And now you can see my my picture is very old because I now have gray hair.
You probably got that from the pandemic.
Exactly. It has been in the last year. But yeah, my name is Carly and I manage infection control here at UHN. And, you know, to start the meeting off, I'd just like to thank you all and happy National Volunteers Week. You guys are amazing. You help keep the hospital moving and flowing and going. And for our department specifically, helping with hand hygiene auditing. We really appreciate what you guys do. Yeah. Maybe I'll turn it over to Alon.
All right, thank you.
Hi, I'm Alon. I'm an infectious disease and infection control physician at UHN. I also want to say thank you to everyone for all your help and all the volunteer hours that you put in. We're happy to help you anytime. If you have any questions, we're happy to talk.
Awesome. Thanks so much. Okay, so I just put this on here because you guys said you were going to deliver a bit of an update. So you guys can go ahead and do that.
Sure. So as you all know, we're in the middle of the third wave now. So the cases have been rising a lot. And especially at UHN, we've seen a lot of cases at Toronto Western. You have 3 dedicated COVID units at that site and 2 dedicated COVID units at TGH. The ICU admissions across the province have also risen dramatically, and more so than the first 2 waves. And basically almost every day we've had record highs up until last week or the end of last week. There seems to be a bit of a stabilization on the pandemic currently. You know, it's all very doom and gloom for sure, but I think it's important for everyone to recognize that there is a light at the end of the tunnel. We know that for a fact based on other countries where vaccination rates are very high. The economies have opened up. For example, Texas. We don't think of Texas as being very COVID friendly, but they are doing a remarkable job and their numbers are falling. Their immunity is probably around 50 to 60% in terms of natural and vaccination immunity. So that's approximately where we want to get to in Canada. If you look at other countries in the world, that's approximately where we want to get to, is 50 to 60% fully immunized. And in Canada, we're not really close to that yet. We're, you know, down between 10 and 15 double immunized, and then about 25% single immunization. So it's going to take a few weeks, but there's definitely a light at the end of the tunnel. There's definitely a way out of this, and it's going to take a few, 2 or 3 months, but we will get there.
I think to add to that too, as Alon said, it is sort of doom and gloom messaging, but also to his point that there is a light at the end of the tunnel, and there are ways to keep yourselves safe. You know, distancing, abiding by masking, staying at home when those orders are in place, like right now, and getting your vaccine. Yeah.
Awesome, thank you. I've been going into the hospital once a week, and so I actually did get my vaccine yesterday. Other than a little bit of a sore arm, we're good. We're good. All right, so thank you for that update. We're going to jump into the questions, and I've actually separated them based on the title of our presentation. We had virus, variants, vaccines, and volunteers. I guess because we're 1 year into the pandemic, nobody really has a ton of questions around the virus. We all pretty much know what COVID is, but we do have some questions around variants. I decided to group them. They're all slightly different, but they are of the same subcategory. So the first one, Laura's got some really good questions for us. She's asking, what makes variants more transmissible and severe? Is there a vaccine type that's more flexible or effective against mutating viruses?
So it's hard to know what exactly it is about the variants that makes them more transmissible. There is changes in the spike protein. That's what we know for certain. So the spike protein is on the surface of the virus, or that it's generated by the virus on the surface of the cells. And we don't know exactly why. To some extent, probably there's an escape quality to it. There's a quality that allows it to escape your immune system. So perhaps with that added to it, you have more viral load, and the viral load leads to a higher transmission rate. We know that's certainly true for some of the variants, but not all the variants. And in terms of vaccination, we know that by far the most common variant in Canada, which is B117, the UK variant, the vaccines that are now available to Canadians, the AstraZeneca, the Pfizer, Moderna, they're all highly effective against B117, so there's no issue there. As for the other variants that are coming from other parts of the world, the South African, the Brazilian variant, there's less certainty around it, but we believe there's still a very high degree of protection with the current vaccination against those variants as well. And even if it's not 100% against symptomatic disease, it's very likely that it'll reduce the likelihood of death, the likelihood of getting hospitalized, and the likelihood of severe disease.
I have a question.
Mhm.
Hi, doctor. How are you doing? Doctor, you said there is two types of immunity, which is by vaccination and by nature. What do you mean, like by nature immunity up against the virus?
So if you acquire the virus, you will have a natural immunity to it because your immune system has seen the virus. That is, if you don't die from it, of course. If you survive COVID, you're now immune against it. We don't know whether there's any difference in immunity between vaccination and natural immunity. So as far as we know, it lasts a fair amount of time. We estimate at least 6 months of immunity from either vaccination or getting COVID, the infection. On top of that, if you do get COVID, if any of you have ever had COVID, you are still recommended to get vaccination. And so there is data that shows that if you get even one vaccine after having COVID, the boosting effect is tremendous and it'll likely have a very long effect. So anyone is recommending a vaccination, even if you've had COVID in the past.
So like the nature immunity, you mean by the B cells function, right?
Yeah, there's a lot of focus about the B cell function and that being the most important. It's the easiest to measure because we can measure antibody levels in the blood. The other branch of the immune system, which is active against viruses, is the T cell immunity, but it's not as easy to measure function there. But no doubt that T cells have an important role to play against COVID immunity, just like they do with other viruses.
Yeah, and I sorry for I read an article on Medscape. They sent me an article. They said like the severity of the virus when the virus attached to the ABC receptors in the lung, which causes the respiratory depression. Is that right? Like, this is the main mortality of this virus or fatality?
Probably the main mortality is associated with the immune response. And that's similar to influenza eggs. For example, a lot of the death related to influenza is because of an overwhelming immune response. And the reason we know that's true for COVID is that the treatments that we know are life-saving, two of them their primary job is just to suppress the immune system. And that's true for a lot of infections, is that it's not the virus directly that harms or kills you, it's the immune system's response to that virus. There is for sure a direct effect of the virus itself on the lungs. But the more severe, what we call acute respiratory distress syndrome, has a lot to do with your immune system's reaction to the virus.
Okay, thank you, Doctor.
Okay, someone is asking, what's the mutation timeline of a virus? What are the determinants for a virus to mutate? Are there markers and signs for when the next major variant will emerge?
Yeah, so the timeline is basically just the longer a virus is alive or is circulating through the human population, the more likely mutants will arrive. So there was, the very beginning when the virus showed up in December of 2019, there was very few variations to it. But as it spread through the human population, the more humans it affected, the more possibility it had to mutate. And this is true for basically every virus we have. Like hepatitis C has 4 common variants. Influenza A has variations every single year, in fact. HIV also has variants to it. In fact, HIV mutates extremely frequently, which is one of the reasons why it's so hard to come up with a vaccine against HIV. So it's perfectly predictable that viruses mutate. Just what's not predictable is the timeline on which they mutate. and whether a mutation arises that it causes the virus to be more adaptive. That's just random, and just through the forces of evolution and natural selection, the viruses that are more likely to adapt are the ones, for example, more likely to transmit are the ones that are going to be more common. So for example, we're hearing a lot about this new mutation that's arising out of India, but we don't know a lot about it yet, but it's certainly possible that if it doesn't have the capacity to transmit as well as the dominant one in Canada, which is B117, then it won't be common. Basically, it'll be outcompeted by the B117. We don't know yet to what degree the new mutations will be, but there's plenty of examples of that with in biology and also with infectious diseases, where certain strains just have certain capacity to transmit more, partly because of people are not immune to it, but it's just inevitable, and we can't predict when these variants will arise.
Yeah. I think the last question there, you kind of already answered a little bit. How do the variants, how do they do arise? And during the first wave in Ontario, was it possible that other variants already existed that we weren't aware? And that was the case, right?
Yeah, when you think about what was going on in December of 2020, before the variants arrived from elsewhere, that circulating strain in Canada was itself a variant. It wasn't the same thing we saw in March of 2020. It already mutated in Canada. Plus, we have a lot of contact with the rest of the world, so there was lots of strains. The difference was that these variants from other parts of the world were variants of concern, which means they actually were different. They caused more transmission and more death. And that's what the issue was with having them come to Canada. Otherwise, there's lots of variations. We don't care about them unless they cause something different clinically.
Right. So I was watching CP24 this morning, and they were saying how the first case of the Indian variant landed in Quebec. And we don't know if that's yet a variant of concern at this point, because we don't know how it's spreading, or?
It's presumably is a variant of concern, but we don't know to what extent compared to the B117, which is the dominant strain here. I guess we'll know soon enough. There's already some preliminary data about the mutations that that variant has. There's a newer mutation that strain has that we don't have a lot of that in Canada. It has one of the other mutations, actually, the E484 that we already know about here. But there's another one it's unclear to what extent it's going to be more infectious. Presumably it is more, because of the pandemic currently in India is in an extremely uncontrolled state. So presumably it is going to be a problem, but to what extent is not clear.
Right. It's crazy how it's almost like these viruses get smarter and smarter with every mutation, right?
Yeah, it's just, they have the opportunity, they have millions of billions of opportunities to mutate, and they do. And it's just like throwing a dart at the board, and one of them's going to hit.
Right. Well, they never land when I throw. All right. So we're going to do some on the vaccine. A lot of these, again, are very similar, but do the UHN COVID experts have any information on whether the 4-month window between the first and second vaccines will be reduced?
I don't know if you've heard anything, Carly, about whether there's been any updates on the UHN side. As far as we know, the healthcare workers are not within that priority group to have the window space. So the document from the Ontario Health identified certain groups to have the windows reduced. That's primarily people with very severe immune compromise, such as those with chemotherapy or transplant. Outside of that, pregnant women, older people, they will still maintain the 4-month window between the first and second. If we have more supply, we ultimately, hopefully, we will get some of those groups vaccinated sooner, and healthcare workers would probably be in that group as well.
I have a question, doctor. Like, it's 2 doses. Like, the second dose is a booster, or like the first dose, the function of it will not be working after like few months, let's say 6 months. So we give a booster second dose, or just it's a part of the vaccine.
Yeah, there's a lot of vaccines that require a second dose to boost. So for example, hepatitis A, we have two boosters. We have 1 booster. Hepatitis B, we have 2 boosters. Measles, yeah, we actually have 2. For mumps, we might even need 3 actually, because there's waning immunity in the adult population against mumps. So the timing of the booster, it's not set in stone for any of these vaccines. When you boost very early, you have an immediate effect that probably wanes sooner than if you boost late. So you're kind of exchanging high levels of immunity quickly that may wane versus long-term immunity, but waiting for it. But when you're in a pandemic like we are in Canada, and there's a shortage of supply of vaccines, the primary goal isn't to get everyone up to 100%, is to get everyone up to 80%, to get as many people first dose as possible. If we were in the States and we had an amazing supply, yeah, we would just give 2 doses to everyone, get everyone up. So it's certainly possible that if you get vaccinated at the 4-month mark, your immunity will last longer than somebody who got vaccinated at 21 days. But that's really not relevant when people are dying and getting COVID today, right? The most important thing is just to get everyone vaccinated now. And so that's the reality. There isn't anything magical about 21 days. There's nothing magical about 28 days. The people who ran the trial in last summer and spring, summer and fall, they just wanted to get the vaccines out as fast as they can, Pfizer and Moderna, because it's a public health emergency, people are dying. So they chose the shortest possible window that they could theoretically use to get a boosting effect. But there's nothing to say that 12 weeks isn't the right answer, 10 weeks is the right, who knows what the right answer is. We'll only know after we collect data after a year or 2 years what the best answer is. If you look at measles, for example, we give the first dose when a baby is 12 months old, right?
Yeah.
The second dose we don't give until age 4 to 6. You can give it anywhere in that window, age 4, age 5, age 6. And that's because we want children to be boosted just before they go to school, to have high immunity before they make contact with other kids. But yes, you can give the second dose of MMR a month later. You can give it 5 months later. There's no harm in doing that. It's just a question of how long your immunity is going to be.
Yeah, and one more question: does like the vaccine or the virus or the variants mutate inside the body mostly or outside? Like, what is the good environment for them to mutate?
Yeah, presumably they mutate inside the humans because they don't survive very well on surfaces, and it needs a virus isn't really alive per se. It needs machinery, the protein machinery of a cell to be able to do anything. So presumably it mostly occurs in humans because it doesn't survive long enough in the environment to do that. So that's the fact that there's more and more humans infected gives it more and more capacity to mutate.
And that's why it's spread more contagious because it's inside the body. Okay. Thank you.
Thank you. Those are good questions. So that's good. Thank you.
Yeah, I'm a doctor too. I'm a medical graduate.
Oh, there you go. So you're having a good conversation with a colleague.
Yeah.
But it's good because sometimes you think of questions that we don't think of asking, right? So thank you. Mm-hmm. Okay, next question. Theories and thoughts behind recent cases of blood clots in AstraZeneca as well as Johnson & Johnson vaccines. Is it preventable, and which groups are it affecting the most?
Yeah, so the AstraZeneca and the Johnson & Johnson use a different modality than the other vaccines that we're using. So to take a step back, the mRNA vaccines, Pfizer and Moderna, how they work is that there's a small genetic sequence that is put into the vaccine. mRNA it stands for messenger RNA or ribonucleic acid. Every human, everything that's alive in the world, vegetables, fruits, cats, dogs, elephants, anything that's alive has mRNA in it. It's an organic molecule, and it's required for you to be able to make proteins in your body. So what it does is just take this little sequence from the virus, you inject it into your blood, your cells take up the virus, your immune cells. They use the sequence to produce a viral protein, and that protein is put on the surface of the cell. And then your immune system comes along, sees that protein and generates antibodies, and that's how you've been immunized. It's impossible for you to be infected by it because it only is a small sequence of the virus. It's not the entire sequence. The AstraZeneca and the Johnson & Johnson, they use a dead virus. They inject you with a dead virus that carries the sequence, and your bodies take up, similarly, you take up the virus and you use that sequence to make the protein. So with AstraZeneca and Johnson & Johnson, it may be that this generation of these clots may have something to do with the vector. And this is also a pretty new vector we haven't used in the past for other vaccines. This vector being a dead virus. It's actually a dead cold virus. Adenovirus is a virus that everyone has been exposed to in their life. So maybe it's related to that mechanism. In any event, the likelihood of getting clots is extremely rare. We're talking about something like 1 in 250,000 to 1 in 500,000. Very, very, very rare mechanism associated with a vaccine. And the people who they've seen it most often is young women. So maybe age 20 to 30 or age 20 to 40. So anyone other than those groups, the likelihood of you getting problems is extremely rare. And even if you are in those groups, it's extremely rare as well. So, and these clots are certainly treatable. They are, of course, they can be life-threatening. And so that's why the recommendations from the National Immunization Council has limited its use in that group. But they've dropped it down to 40, recognizing that we need to get people vaccinated ASAP and the risk of clot is quite low. So it's not really preventable in any sense. It's not like other clots that people develop. If you're on a blood thinner, it's not going to necessarily prevent this kind of clot. The mechanism is very different from all the other types of clots we develop. It's like a drug-induced specific mechanism that is very different. So that's the clotting story there. Still very rare.
I think it's important to note too that now that they have seen some cases, the symptoms are recognized, the issue is recognized, and it's quickly treated.
Lori, you raised your hand. You want to turn on your camera and ask something?
Yes, please. I'm just wondering if I've already had the first dose of AstraZeneca and no issues. Is it safe to say the second dose then would be smooth sailing?
Most likely the answer is yes. So an analogous situation is a drug called heparin. Heparin is a blood thinner that's used for a variety of reasons. And heparin, in very rare circumstances, causes something called heparin-induced thrombocytopenia that actually causes clotting. It's an unusual mechanism, but the point is that generally speaking, when we see people have used heparin and they haven't had that reaction, we deem it safe for them to continue using it. The vast majority of people do fine on heparin, but the only time we say don't use heparin is if you actually had a reaction to heparin, this specific reaction. So presumably if you had the first dose of AstraZeneca, the likelihood of getting a reaction to the second one would be very, very low, would be even lower than the very low even lower than 250,000, for example.
Okay, thank you.
I apologize for that window that says, please move this window away. I don't know how to get rid of it. Okay, thank you for that. So the next question is, any publications on effectiveness in mixing vaccine types? So 2 doses, same type, but different brand. And if no, what's your opinion on best combination?
Yeah, so there's no trial that will ever do that because they're all different companies. So there's no incentive for Pfizer to mix and match vaccines because why would you do that? And there's no good reason to do that anyway. I guess the only reason you would is if one vaccine runs out of supply. We don't know the answer to that at all. We don't know whether you can mix and match. The advice is not to do that at all. And if it is done, I assume that the only way, safe way to do it is just to mix and match 2 mRNA vaccines rather than 2 different mechanisms of vaccines. But there is no best combination in that sense because you're not supposed to mix them up anyway.
Okay. And for those who have drug allergies, for example, penicillin, if given the choice, is there a vaccine type that is better? So vector over a subunit or an mRNA vaccine?
So with allergies, one thing important to remember, first of all, with penicillin allergies, because this is also an infectious disease topic, penicillin allergies are frequently incorrect or mislabeled. So out of 10% of the population claims to have a penicillin allergy, but only 10% of those people actually have a true allergy. So the vast majority of people who think they have an allergy don't have an allergy at all. But let's assume you do have a true allergy. The likelihood of you reacting to any vaccine or any drug for that matter is definitely higher than the average population. But the relative risk is higher, but the absolute risk is still very, very, very low. So for example, if you start taking a new medication, if you have a penicillin allergy, your likelihood of reacting to that is higher than the average person. But still, it's very, very low. So some people are just predisposed to getting allergic reactions than others. Their immune system is just more likely to react. So if that's the case, it's going to be similar whether you take an mRNA vaccine or others. The best data that we have so far comes from the Pfizer because there's the most doses of that given in the United States. And the likelihood of reaction to the Pfizer exceedingly rare. It's like 1 in a million. So probably it's higher if you're a type of person who gets reactions in general.
Right. Okay, thank you. And actually, you kind of touched on this a little bit. Should we be worried about potential long-term consequences of the vaccine since human trials haven't been around long enough to discover if any exist?
So a very important point there was made by Dr. Fauci in the United States when he was asked this question. A very important observation that he made is that if you look at any vaccine that's been rolled out in the last 100 years, there have been documentation of permanent side effects associated with them, but they have occurred within the first 60 days of vaccination. They're rare. So for example, in the 1970s, there was a batch of flu vaccine that resulted in some permanent neurological deficits in people. That was about 50 years ago. Those side effects showed up essentially immediately within the first 60 days. So when they did the trials, and based on the data we have far more than 60 days worth of data. We have 6 months worth of data now. So triple that length of period. And even still, most of the reactions occur less than 60 days, occurs within the first 20 or 30. So the point is, if there is such a thing as a permanent side effect from a vaccine, they occur immediately, very quickly after you've got the vaccine. So if there's not a high likelihood to believe that we're going to get any permanent side effects from these vaccines. The other thing to point out is that mRNA is an extremely fragile molecule. In fact, as you all know, in the beginning, Pfizer required these very cold freezers for mRNA transportation because it's so easy for this molecule to degrade. When it gets into your blood, it degrades within a few hours and then it's gone. So even based on that mechanism alone, it'd be very, very unlikely that you're going to have any permanent side effects. Same with the vector, the adenovirus vector. These things, they degrade very quickly. And so it's very unlikely that you're going to have reactions after 60 days or that we're going to have permanent side effects from any of these things.
Is that the same for the flu vaccine? The annual flu vaccine?
Yeah, so the flu vaccine is an inactivated form of the virus. But yes, the likelihood, a good example of that is, so the likelihood of you getting a permanent neurological deficit from flu vaccine is about 1 in a million. It's called Guillain-Barré syndrome. If you get flu, the virus, your likelihood of getting Guillain-Barré syndrome is similar or slightly higher, just to give you a sense of the risk be from vaccination or from the flu itself. Similarly with COVID, of course, the risks of getting permanent damage is much higher than the vaccine.
Right. Okay, good. All right, I'm going to move on, but don't worry, guys. If you have more questions at the end and we have time, we will get to them. So some of these questions are about the volunteers and volunteering in the hospital. You know, now that right now most of our programs are on hold, we have very small amounts of volunteers who have come in, and those were considered Group C. So most of them did get vaccinated prior to restarting with us. And we're talking like a handful of people, those working in the vaccine clinics, et cetera, right? So somebody asked, will the COVID vaccine become a requirement to volunteer on site in the future? Hard question, right?
You want to talk about that, Carly?
Yeah, sure. I mean, I'm not sure we can speak to that, to be honest. It's more of a health services question. However, it has not been made mandatory among staff, and that's actually a very difficult thing to do. So I think it's very doubtful that it would ever be mandatory.
Some of these questions may be hard for you guys to answer because, like you said, it's kind of hard to, like, considering that they don't have answers even for staff at this point, right? What would be the hospital's new guidelines for volunteers once the cases of COVID-19 are under control, or once we reach herd immunity? Again, I think it's something we have to wait and see, right?
Yeah, I think we have to wait and see. And to be honest, I'm not sure much will change. I mean, vaccination will be encouraged. I think distancing and masking will stay in place for quite a while, if not forever. And other than that, yeah, volunteers would go through the same orientation, speaking to safety and infection control measures that they would have before.
Yeah. Masking forever makes me sad. I miss seeing people smile.
Doctor, I have a question. Like the patient who have high risk for blood clot and taking the AstraZeneca vaccine, we cannot give them like low molecular heparin for prevention of this clot? maybe during the history, we can take the history for the patient.
If you get a clot as a result of the vaccine, you definitely will be on probably heparin to clear the clot or prevent future clots. But as a preventative measure, it hasn't been recommended, probably because it's extremely rare, and you'd have to treat like several, you'd have to give that drug to several 100,000 people before you see any kind of benefit, which is a really crazy risk to benefit ratio.
Okay, does that answer your question? Okay, so Marianne is asking, she hasn't been vaccinated yet, and she obviously wouldn't want to put herself at risk coming into the hospital, and is asking if volunteers are going to get vaccinated. As far as we know right now, Marianne, volunteers, just like all the staff that are in Group E, which are mainly work from home staff that don't come into the hospital, are not getting vaccinated right now within the hospital. We're being asked to do it in the community if possible. Maybe Debbie, are you there? Debbie Talbot?
Yep.
Is there anything that you can say that maybe I don't know about this?
No, I would guarantee that if your turn comes up, we have a phased return to service plan that I have created. So as we phase the volunteers back into their roles, we'll do that, of course, keeping everyone safe. If you're asked to return or offered the opportunity to return, you will be offered the opportunity to receive a vaccination if you haven't received one already.
Thank you. And for those who don't know, that is Debbie Talbot. She is the manager for VR for Toronto Rehab and Princess Margaret. Okay, would it be possible to open up volunteering in some areas where one would be behind plexiglass helping with some clerical work?
Do you want me to do that too?
Sure.
So again, we've got the phased approach to bring people back. We have a very small number back on site. We have looked at some of those areas. Those are mainly the clerical admin support areas. They just have not been deemed essential enough at this point. And the other challenge we came up against was the physical distancing. So while it's great that you could come in and help the admin staff, and I'm sure they would love your help, we couldn't guarantee the 6 feet of physical distancing at all times while you were behind that plexiglass. And I don't mean 6 feet from the patients, because that's a little easier to do. I mean the 6 feet between the other clinical staff and admin staff within that area.
Okay, thank you. That makes sense. And one of the last question there says, will UHN put the COVID-19 vaccine on the list of immunizations for the health form volunteers must complete to volunteer at the hospital? And this is the same form that staff needs to fill out. So maybe Carly, you can take this one.
Yeah, I think similar to the question earlier, we have not been able to mandate this for UHN staff at all. So I don't think it would be mandated for volunteers. Of course, I can't predict the future, but that's where it stands right now.
All right, thank you.
Yeah.
So that was the questions we got through Slido. I'm going to check the chat now and see if there is anything happening there. Mars is asking, is the virus like an AI virus now? I don't know what that means.
Well, the adaptation of viruses is nothing new. Every living thing mutates or has the capacity to mutate, and natural selection is one of the forces of evolution that will select for the most adaptive viruses. So it's nothing crazy going on here. I mean, it is in the sense that it's harmful, but not, it's pretty much par for the course in terms of living things to mutate.
All right, and we have, what will life look like after 2 vaccinations?
Well, in Israel, where the highest rates of vaccinations, they're approaching 60% with 2-dose vaccines, and they have more than 85% of their elderly population vaccinated. So life there looks pretty normal now. There's still some masking, there's still a little bit of restriction, but most economic activity has been opened up. The UK has also done an extremely good job with the AstraZeneca, giving it to millions of people. Their case numbers have come down, and they're about to have wide-scale opening in May of various large events like sporting events and clubs and bars and that kind of thing. So we will know from them as well how things are going. It'll take some time for things to be normal, But I don't know, even going back to the Texas example, in the first week of March, the governor opened everything up, no masks, no restrictions on business, and cases haven't gone up.
Oh.
They're doing very well. The cases are only declining in Texas. So there's a good example. Same thing with Mississippi as well. They, last 6 weeks, they opened up completely and they've been doing very well. They also had relatively good rates of vaccination.
Mm. So it's just a matter of us getting those vaccines into people's arms.
That's right, folks. Our ticket out of this is getting everyone vaccinated. We're aiming for, again, somewhere around 60% at the minimum of everyone being immunized.
What would you say to somebody who's super, super hesitant, who's just like not really up for it? I don't want to do it at all.
I think it's important to, every person has personal beliefs. It's important to ask why. There may be a variety of reasons. It may be misinformation. It may be a question that needs to be clarified. It may be a lack of experience with vaccination. Everyone has their own reasons. We should explore every single one of them to understand why. The highlights, I'd say, is if you get vaccinated, you turn this disease from killing you to a cold. That's all it will be. 2 doses. After you've been given 2 doses, you'll never die of COVID. You'll get a cold at worst if you pick it up. The second is that it's one of the safest things that you could imagine. Like, talk about the risks we take on a day-to-day basis. You talk about the drugs we take. You get a heart attack, you get put on a statin. The benefit risk ratio is nowhere near as good as this vaccine. It's our wildest dreams a year ago could never imagine how good this vaccine is. It's like something out of a miracle. So those are the 2 most important things, is that it's extremely effective and extremely safe.
I think that until you see somebody who's had it or have experienced it yourself, sometimes that's the kind of rude awakening you need to go ahead and get it. I know that January last year, before all this started, I had gone to Las Vegas with my husband. And when I got back, I didn't know anything about COVID. I got the worst flu of my entire life. I was knocked out for 5 days. I ended up in the ER because I couldn't breathe. And I'm otherwise very healthy. I don't know that that was COVID or not, because it was already kind of happening around that time in the States. But it was enough that when I got so scared that I never want to feel that again, that I want to get a vaccine. So I think that sometimes, until you see somebody struggling, you don't know what it can look like. And I think sometimes it's a little bit of scare tactics, but it's what we're missing, in the media a little bit. Sometimes it's just these kind of stories to really kind of put them in people's faces and be like, this is happening, right?
Yeah. My view on the world generally is that the universe is trying to constantly kill you.
Yeah.
You don't have control over most of it, but when you do have control, you should do
Try.
your best. Just do it.
Well, it's that whole pandemic every 100 years thing, right? Every 100 years, the earth cleanses itself of some people.
But there's diseases, there's car accidents, there's hurricanes, there's all sorts of things that you have no control over, but you have control over this, and it's mind-blowing how low risk and how high benefit it is. We hardly ever come across this in medicine. You get a surgery to remove a cancer, you take a drug to prevent a heart attack. Those things are so risky, and this comparatively very little. Very little,
yeah. It's so new, right? And people are scared of new, and they're scared of change.
Exactly.
Somebody wrote, if after you have taken 2 doses of the vector vaccine, a year from now, when you need another shot, can the vaccine be mRNA?
Yeah, again, we don't know whether that's going to be needed, but presumably after you finish your 2 doses of any vaccine, it's certainly safe to take anything after that. You can, Thanos, you can collect all 5 of them if you want. It's not going to do you any harm, but it doesn't mean it's going to be any benefit to you. But if we need it next year, there's no reason why you couldn't use a different type of vaccine. With flu, there are a variety of flu vaccines, and over the years, if you've been vaccinated, you've probably been exposed to a variety of types of flu vaccine. So that's probably what it's going to be like. Just like with flu, we narrow down which groups should get which vaccine. The same thing will probably happen with COVID.
All right. All right, I'm going to attempt to read this out because Zam is clearly much more technical than I am. Is supraclavicular lymphadenopathy side effects of Pfizer vaccine?
So that's what they're referring to as getting like a lymph node above the clavicle. So the head and neck lymphadenopathy is a very common thing to happen as a result of viral infections or bacterial infections of the head and neck. But as far as I know, that's not a common side effect of the vaccine. It may have occurred in some people, but it would not be a common side effect of this one. It would be, and even if it did occur, it would not be a life-threatening infection or life-threatening complication. It would be benign.
Okay. Somebody asked, why don't we have a blood work process in place to determine if people got COVID or not, rather than only PCR?
So there are serology tests available generally in research settings. There isn't much value in doing serology on a clinical basis because the PCR tells you about active disease, whereas serology tells you about previous disease. So like with most infectious diseases, they're complementary and you might use both depending on which infection you're talking about. But generally speaking, we don't really care if you've had COVID in the past so much as caring if you have COVID right now. Of course, there are exceptions, but that's why the PCR is so widely used. It tells you about what's going on right now.
Right. And
Doctor,
so,
I have a
go ahead.
question. Sorry for that.
Yeah.
Does vaccination lowers the mutation rate inside the body, or just like prevents you from getting the virus?
Yeah, presumably if you're immune to COVID and you're exposed to COVID, the virus won't have the capacity to replicate or mutate inside you, or it would have a very, very limited capacity to do that.
Okay.
Great. Wonderful. Thank you. So sorry, just to go back to your last point, and this is just me asking out of curiosity. So I know that you said you don't care so, like research doesn't care so much about whether you've had it in the past compared to what you have. Could that not help with us determining herd immunity though, if we know how many people have had it?
Yep, so if you're looking at, so that's why it's used more for research purposes or public health purposes rather than clinical purposes.
Right.
So if you are coming into the ED, it's not as valuable to do a serological test, it's more valuable to do a PCR test. But a lot of research studies have been done to look at herd immunity, and that's where serology is most helpful. So, and that's where data comes from, gives us a sense of herd immunity. As I mentioned earlier, like the natural immunity and the vaccine immunity combined is where we want to get it up to around 60%.
Right. Because I know that I'm part of the Ontario Health Study, and they were sending out serology little tests to kind of collect the data to see. So if anybody is ever interested in actually knowing if you got that, you can sign up for the Ontario Health Study. Not that I'm plugging it, I'm just telling you. Okay, we've come to the end of our questions that I had. If anybody wants to ask any more questions in the chat or unmute yourself and ask a question, please go ahead. We'll wait a few minutes or a few seconds. So can you tell us while we're waiting and just to see if any questions come in, what can people expect right after they get their vaccine? Like for me, it's like a little swelling in the arm, like your typical flu vaccine. I have a bump, you know, it's a little bit hot, hard to move.
Yeah, with Pfizer and Moderna, it's extremely common to get side effects like sore arm, muscle aches, sometimes headache and fever. But all of these symptoms will resolve within usually they arrive within 24 to 48 hours after vaccination, but they all resolve after 48 hours. So don't be surprised if you get these side effects. It's totally normal. If you get shortness of breath or cough or sore throat, that's probably more likely to be COVID, in which case you should get tested. But if you have a transient fever or transient headache or muscle aches, it'll probably go away quickly after that. You don't need to take any medication before getting vaccinated. If you have these side effects after the vaccination, you don't necessarily take anything. If it's very uncomfortable for you, you can go ahead and take Tylenol, but you don't have to do anything before or after.
Okay, thank you. I found that a nice pack, kind of just helped the heat go down and made me feel a little bit better. Okay, somebody's asking, more clarifying, please. If, for example, Veronica had COVID after her Vegas trip, is it okay now that she got vaccinated? I sure hope so, because I did.
Yeah, as I mentioned earlier, if you've had COVID, you're encouraged to get vaccinated. It'll provide you a long-lasting immunity if you get vaccinated. With regards to the other question here about blood work to test for COVID, yeah, I mean, as I said, you can still do blood work. It has more of a purpose on a public health level or a research level, not as much importance on a clinical level when you're seeing patients in the hospital.
Quick question about getting tested for COVID. I know the nasal swabs are the #1 way to go. I know that they've come up with like saliva spit for, the little kids and such. A friend of mine's son got swabbed on the inside of his cheeks. Is there one that's 100% better than the others, or?
Yeah, there's a variety of testing modalities. The generally most common used is nasopharyngeal swabs that are sent for PCR testing, but there are other modalities like using the nares, swabbing the nares, or just the nase, like the anterior portion of the nose, to do rapid testing. Carly, you want to speak about that?
Sorry, my internet just went down for a second there and I only heard part of your answer, so I may be repeating myself, but yes, the PCR test is most sensitive. I do know they are sharing the nose and cheek swabs through the school system. It's less sensitive, but you get more compliance with children. If you've had to take your children for a nasopharyngeal swab, you know what I mean. It is not fun, and you can only bribe with McDonald's so many times. I don't know if I have anything else to add to that.
No, that's great. Thank you. Maybe I can just ask you guys, why does it feel like it's pool water entering your nose? Because that's what it felt like for me. It felt like when I got it done, I was like, oh, it burns, it stings. I think it's just that liquid that it's in, right? That like whatever solution it's in.
I think that feeling that anything going up your nose feels wrong. And probably the most familiar time that happens is jumping into a pool.
Yeah, probably. I don't know. I have a deviated septum. All sorts of things get up my nose. So it was still not comfortable, but you know what? It was beneficial. And I got my positive. So, my negative test. So it was good. So Katie says, water up the nose is perfect way to describe it. Thank you. I thought so too. Okay. Well, it doesn't look like there's any more questions. Is there anything you guys wanted to say, kind of wrap up?
Get vaccinated.
Yeah.
It's the only way out of this. I encourage everyone here, if you have family members, encourage them, go online, check your vaccine, your availability. It's the only way to prevent these things from getting worse. It's our only way to go back to normal. If you enjoyed life before the pandemic, then get vaccinated. If you enjoy life now, then don't.
We can't get when we can get the vaccine, like for 20s people, like because I read just for 40 and above yesterday.
Yeah, hopefully in May we will be moving on to phase 2 is going to take some time. Hopefully in the end of May we'll be moving to phase 3, but who knows, if the vaccine supply improves, we'll move to it faster.
And phase 3 includes
everyone.
Yeah.
If you live in a hotspot area, though, you can get vaccinated at 18 and above. So some hotspots in Ontario can start even now. So I just encourage you to check online, the Toronto Public Health website, or Peel, or Durham, or York Region. Check your availability and your,
And it is specific to your postal code. So you have to look up your postal code and figure out if you are considered a hotspot.
So I have a question. I don't know if you guys answered this already. If someone tested positive, how long do they have to wait to get the vaccine? Like, can they get the vaccine after symptoms, or how does that work?
Yeah, we don't actually know the right answer, but it would make sense to wait a few weeks. We don't have any guidance from the province or the federal government about how long to wait. But it's certainly safe to get vaccinated after COVID. We just don't know what the optimal timing might be. So after a few weeks, it's certainly reasonable to go book yourself a test if you've had COVID.
Also, what about kids, like the vaccine for 16 and under? Like my son is 15, and I 16 later on, but later on this year. But I wanted to know, like, is that something that's going to happen? Like the vaccine will go under for adolescents under 16?
Yeah, so Pfizer is the only one that came out with data so far. They did a 12 to 16 study, and as expected, it's perfectly safe and highly effective in that group. The question will be is that when will be the best time to do it, because under 18 is not a priority because one, they almost never have bad outcomes, and two, the younger you are, the less likely you are to transmit, presumably. But so probably the next age group after 18 will be 12 to 18. When will that group be? Probably in the fall of 2021, because the goal is to vaccinate everyone 18 and above by September. That was the original goal. Hopefully we can get it done sooner. But I'll bet you that by the end of 2021, anyone 12 and above will for sure be recommended to get vaccinated if we have the supply to do it, and if COVID is still common enough.
Do you see it being, because my son is 5 and he gets his flu shot every year, do you see it being something that even smaller children can get?
Yes, I think maybe in a year from now, it'll be part of the infant vaccination series.
Yeah.
Once we have data, we just don't have it yet.
I actually wondered, and this is just me being a paranoid mom, but I kind of feel like at this time we are making a little bit of like bubble children because they're not being exposed to almost anything right now. So I always wonder if we're actually doing a little bit more harm than good sometimes with keeping all of these measures so tight around the kids.
Yeah, I mean, that's certainly the discussion in the United States now with the cases coming down. There's a lot of controversy about whether schools should remain closed or open. And basically boils down to what the community cases are like. And really, we should be opening schools as soon as possible. As soon as cases in the community fall, we should be opening up schools. That should be the first thing we open, really.
Yeah. Let me tell you, for mom's mental health, that should definitely be the case.
Yeah. Doctor, do you think in the near future we will be having third dose? Because as we know, it's a pandemic and there is so many new variants are becoming. So when will we end with this? Do you have any measure of that?
We don't have any answers because it's too early, but the CEO of Pfizer said we're going to need a dose next year, but that's exactly what you expect the CEO of Pfizer to say.
So yeah.
But the proof will be in the pudding. It'll be obvious to everyone whether we need a third dose. And that's because the cases will come back.
Sure.
If the cases come back and the variant is different, then it'll be obvious that they need to rejig the vaccine to cover the variants, which they've already started doing, and we need to get vaccinated again. But if in January 2022, the cases are minimal, the hospitalizations are minimal, then what would be the value of vaccinating people a third time? There wouldn't be much value. You'd have to think about it carefully and do probably a selected group of people to vaccinate. Even if we had a vaccine against the common cold, we probably wouldn't be vaccinating people against it, or at least spending a lot of money doing it, because nobody gets hospitalized for the common cold. So if that's what COVID ends up being, like most coronaviruses are, then it would not make sense to invest a lot of money and resources to keep vaccinating against COVID if all it is a cold.
So is the severity of the virus similar to for the high risk people, old age with heart failure, kidney? It's the severity of corona similar to the flu, which can't take them to the.
It's probably worse than the flu, but if the cases are still common enough, what you might see is targeted boosters in those populations. There might be more boosters in like elderly and the immunocompromised. So pneumococcal is a good example of that. So pneumococcal pneumonia, we vaccinate babies against it. We also vaccinate old people against it, or people with certain chronic conditions. If you're 30, you're not getting a pneumococcal vaccine because your chances of getting pneumococcus is extremely rare. Strep pneumo, the organism. So we already have that in society. We already have certain vaccinations which are for targeted high-risk groups. So babies and old people, essentially. That's what COVID may end up being, is just targeted high-risk vaccination.
That's really good. Thank you very much. Okay, I'm going to be mindful of everybody's time. It's 1:58. So I want to thank Carly, and I want to thank Dr. Vaisman for your time. This has been very eye-opening. I'm sure everybody really enjoyed the session. So I just want to say happy National Volunteer Week to everybody as well. And if there's anything else, you guys can write it in the chat. I'll leave it open for another minute. If not, we're going to say goodbye. Thank you very much, guys.
Thank you again for all you do.
Thank you.
Thank you.
Have a great day. Thank you.
I used to volunteer at the hospital.
Oh, yeah, we love to hear that.
I did. At Mount Sinai, I volunteered for like 600 or 700 hours.
Oh, wow.
Yeah.
Why not UHN? Why Mount Sinai?
I knew the volunteer coordinator. I don't know if you know them.
You had an in.
Yeah, exactly. So I spent a lot of time, volunteering at different places at Sinai.
That's awesome.
Yeah.
Back when I was a wee
I
lad.
did as well.
Oh, did
Yeah.
you? Yeah.
Yeah, in my hometown, not in Toronto, but yeah.
And look where you guys are now.
Yeah.
See, guys, volunteering is good. Gets you places.
We need volunteers.
Thank you very much. Thank you. Bye.
Thank you.
Thank you, everyone. Wishing you a great day, okay?
Bye.
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 Thanks, Veronica. Bye-bye.
Thank
Thank
you.
you.
Bye, everybody.
Bye-bye.
Bye-bye.
Bye.
Bye.
Thank you.
Thank you.